Good afternoon, everyone. Welcome to the CPEN webinar, Support and Education for Caregivers, Describing Programs and Resources to Meet Their Needs. My name is Jackie Foster, and I will be the moderator for today's presentation, and Paige Hulsweiser will be your headquarters support person. This webinar is brought to you by the CPEN Professional Development Committee. If at any time during the event you require technical assistance, please use the chat function on the right side of the screen to send a message to headquarters support. If you prefer to speak to someone directly, you can contact headquarters at 434-284-4697. There will be a Q&A session at the end of today's presentation, and so you're welcome to submit your questions to headquarters support at any time using the chat function. I will present these questions to our speaker at the end of the presentation. This presentation is also being recorded, and the recording and resources presented will be available through the CPEN website. And now it's my pleasure to introduce our speaker for today. Erin Kent, PhD, MS, is a scientific advisor for the Outcomes Research Branch in the National Cancer Institute. Previously, she served as an epidemiologist and program director, also in the Outcomes Research Branch, and was a Cancer Prevention Fellow in the Office of Cancer Survivorship. Dr. Kent has a background in mixed methods research and community-based participatory research. She has led a research program in informal cancer caregiving, including the establishment of funding opportunities to develop interventions for cancer caregivers, a small business innovation research concept to develop digital platforms to connect cancer caregivers to care delivery teams, and efforts to expand observational research to further characterize caregiver burden. She has recent publications in several journals, including the Journal of Clinical Oncology and Cancer Survivorship. These publications cover many topics related to cancer caregivers, including research and clinical priorities, employment implications, and skills training. Dr. Kent received her PhD in Environmental Health Science and Policy with a concentration in Epidemiology and Public Health from the School of Social Ecology at the University of California, Irvine. Thank you so much for joining us today, and I will now pass this over to our speaker, Dr. Erin Kent.
Great. Thank you so much, Jackie. It's wonderful to be speaking to you all today with the Cancer Patient Education Network. So hi to all of you out there. It's a pleasure and an honor to be here to talk to you today about caregiving and cancer, and I'm going to start by giving an overview of sort of where I'm situated at the National Cancer Institute and some of the work that we do. Okay, so I have been at NCI for about 7.5 years, starting first as a Cancer Prevention Fellow and then as a Program Officer or Program Director for 5 years. And now I work as a Scientific Advisor at ICF, working on areas related to patient-reported outcomes, patient experiences of care, and informal caregiving. However, this past summer, my family and I relocated to North Carolina in Chapel Hill, so I now work remotely for NCI, so I just wanted to give you a sense of where I am located geographically. And to further situate my talk, I just wanted to provide some context regarding the program at NCI that I help support. So this is our schema for the Healthcare Delivery Research Program, which was launched in 2015. Our mission is to advance innovative research to improve the delivery of cancer-related care. And as you can see here by the schema, we keep the patient at the center of what we do and the research resources we develop and the grants and contracts that we fund. So we have 3 branches in our program: the Healthcare Assessment Research Branch, the Health Systems and Interventions Research Branch, and then the Outcomes Research Branch, which is where I work. And the mission of the Outcomes Research Branch is to coordinate and sponsor research to measure, monitor, evaluate, and improve patient experiences, health outcomes, and quality of care across the cancer continuum. So much of our signature work can be summed up by the phrase patient-centered outcomes research, which seeks evidence to help patients answer some of the questions that you see here. So questions like, given my personal characteristics, conditions, and preferences, what should I expect will happen to me? What are my options? What are the potential benefits and harms of those options? What can I do to improve the outcomes that are most important to me? And how can clinicians and care delivery systems they work in help me make the best decisions about my health and health care? So the focus on the cancer patient by ORB, by PCORI, and by comprehensive cancer centers and many organizations has led to enormous strides in research being more relevant, more helpful, more expedient, really more human and more effective. And it has been and I will be continued to be very effective. But inevitably, when a frame is put around something, it crops out a lot of context. And that context is largely what I want to talk to you about today. So wondering if you out there in cyberspace recognize this person. Some of you might not. However, how about now? So I think many might not have recognized that face without the context of the whole photo, even if you haven't seen the movie from which this photo was taken. So this is the Portakalis family from the movie My Big Fat Greek Wedding, a movie about a lovable, zany family and all the energy, struggles, conflicts, and celebrations that being part of a family entails. And just as in the movies, in healthcare, family matters can be messy, simply put. But the point of that is that family matters don't just exist outside the clinic walls. Family matters. Patients do not live in vacuums. Most cancer patients have someone they rely on and who in turn relies on them. An individual person or family or a set of close friends or other individuals on which they rely upon, care about, are influenced by, share resources with, provide to, share exposures, habits, homes, and health. And to omit this is not only missing the full picture, but it's missing perhaps the most important part of the picture. So as Jackie mentioned in my intro, I received my PhD from the School of Social Ecology at UC Irvine, and I was brought up on the social ecological model of health, and many of us use it to guide our work. And here's one version in which family is portrayed as the second ring in the model. Research on caregiving recognizes that individual cancer patients and survivors come from a social context, some kind of family broadly defined. How quickly they get in to see the doctor, get screened, get diagnosed, get treated, get second opinions, what treatments they get, how adherent they are to treatment, how well their symptoms and side effects are managed, how their mood and well-being are faring, how they're coping, and so on. And how well they transition into survivorship, and frankly, even how well they die, are all likely to be related to their family, to their caregivers. So there are various definitions of what is meant by an informal caregiver, but this is what I mean by informal, or sometimes the word family is used for caregiver. So what I mean is individuals that are assisted by family members or friends who provide care which is typically uncompensated, usually at home, and often involving significant efforts for an extended period of time. And importantly, it's not so much what caregiving is as what caregiving does, because it can require many demanding tasks, including monitoring for side effects, managing symptom burden, helping a patient make decisions about their treatment, coordinating sometimes numerous healthcare providers, triage, whether to take someone into the emergency room or if a problem can wait till the morning or be on the weekend, administering medication, technical medical tasks. And in cancer, that can include things such as managing ports and catheters. And in addition, managing a patient's financial and social obligations in concert with a caregiver's own. The nature of cancer, in contrast to other chronic illnesses like dementia, for which we often are talking about impact on caregivers, can be unique. And certain ways in which cancer can be unique is that it can present with a person having a rapid deterioration of their health over a short period of time, which can cause heightened distress among a family. And actually, many cancer caregivers report cancer-specific stress that can have a measurable impact on physical health and even immune functioning. Cancer patients can experience more variability in symptoms and toxicities from the various multimodal therapies than do individuals with other chronic illnesses. And this can necessitate that caregivers monitor their patients' health status frequently and use a variety of technical and psychosocial skills to promote their patient's health. Cancer caregivers typically spend more hours per day providing care, provide more intense care over a shorter period of time, and are often more likely to incur out-of-pocket expenses than do caregivers of individuals with other chronic illnesses. And in addition, there's a pretty common concern about disease recurrence, which can be stressful not only for a patient, but for their families as well. And patients themselves report often that the impact of cancer on their family is a high source of cancer-related stress. So Cancer Care, an organization that is dedicated to assessing and promoting cancer patient and survivor and caregiver health, conducted a survey on patient access and engagement and published these results in 2015. And what they found was that actually for all ages, they broke up their sample into 25 to 54-year-olds and 55 and older, that for all ages, the impact of cancer on family was the highest source of cancer-related stress, although even more distressing for patients in the younger age group. So patients are actually saying that the impact of cancer on family is hugely important. And in addition, something else to consider about this picture is that thanks in large part due to better treatments, earlier detection, and the aging of the population, cancer prevalence is actually rising, and even more so in older adults, so older than age 65. So there's an estimated U.S. cancer prevalence growing to, in 2040, which is only actually 23 years from now, about 26.1 million. And although not every cancer survivor may have or at least report having a caregiver, we can expect that as the number of cancer survivors continue to grow, the number of family affected by cancer and the number of cancer caregivers is also expected to increase. So in the spring of 2015, along with colleagues at the National Cancer Institute and the National Institute of Nursing Research, I led a two-day meeting with over 75 attendees to discuss the state of the science, research, and clinical priorities for informal cancer caregiving. And we published the results of that meeting in the journal Cancer. And I want to go over some of the 4 areas for which we had findings and recommendations to help kind of organize sort of where the state of the science and opportunities for resources now are. So these are our 4 areas that we looked at in depth and then came up with some recommendations for. So the first was improving the assessment of both the prevalence of caregivers and caregiving and really better characterizing the burden of cancer caregiving. The next was improving interventions, so helping to improve both the number of and the quality of interventions that support both cancer, not only support cancer patients, but also cancer caregivers. Maximizing the positive impact of technology, so recognizing that the technological landscape is changing, and so how do we best harness that, those developments and not sort of get sucked into the pitfalls of technology as well. And then facilitating better integration of caregivers into the healthcare delivery system. So I'll start with the prevalence and burden area. So the NCI, along with the National Alliance for Caregiving and the cancer support community, had an opportunity to take a deeper dive on a survey that the National Alliance for Caregiving has been conducting about every 5 years on caregivers across the country, sort of broadly speaking. So this is a survey that they conduct of caregivers themselves. One of the challenges in trying to characterize caregiving is that a lot of the information that we get is often secondhand, often from patients themselves, about their caregivers. This survey is actually from the perspective of caregivers. And one of the questions that is asked on the survey is, what is the main problem or illness for which you were providing care to your care recipient? And so what we found from that report was that approximately, and based on, because this survey was based on an online probability sample, we made some prevalence estimates of people for whom said that they were serving as a caregiver for someone for whom their main problem or illness was cancer. And from that, we extrapolated that around 2.8 million adults were currently serving as a caregiver to another adult with cancer in the U.S., spending about an average of 33 hours per week caregiving, which is quite a lot. 43% of those individuals indicated that they were performing complex medical or nursing tasks without any prior preparation or training. 50% reported high emotional stress, and 25% reported high levels of financial strain. And I'll take some of these findings in a little bit more detail. So what we did in this report was we compared cancer caregivers to non-cancer caregivers. And what we found was that cancer caregivers were more likely to be caregiving for a shorter period of time, but that care was typically more intense by measure of hours providing care, and also activities of daily living for which the caregivers were providing assistance. So that's actually why we subtitled the report An Intense, Episodic, and Challenging Care Experience. And we also looked at the number and type of activities of daily living that cancer caregivers were providing support for, as well as instrumental activities of daily living, which you can see here in these two graphs. So, you know, whether or not the caregiver was helping out with toileting, bathing, feeding, getting dressed, getting in and out of beds and chairs. And what we saw for the activities of daily living was that cancer caregivers were more likely to endorse each and every one of those ADLs. For the IADLs, they were more likely to endorse that they were helping with arranging for various support services for their care recipient, or that they were helping out with administering medications, pills, or injections. And that the number of tasks that cancer caregivers were providing support for was higher among cancer caregivers than non-cancer caregivers. We also found that 62% of cancer caregivers were reporting that they were in what we would call a high burden situation, measured by the number of hours of 20 or more hours per week, and whether or not they were assisting with ADLs compared to non-cancer caregivers. And importantly, as I mentioned, about 50% were indicating that they were in a situation that was stressful as measured by a 1 to 5 scale, versus non-cancer caregivers at about 37%. And so taken together, this kind of gives you a picture of what caregiving looks like in cancer in the U.S. Today. Now, it's always good to have several sources of data when we're trying to characterize a health problem. And these additional bullets on this page indicated some other sources of data for which we have information on caregivers. Each one is a little bit different, though. So from the Medical Expenditure Panel Survey, or MEPS, we found, which is a survey of healthcare utilization and impact of health on employment and any financial problems that also might ensue with health changes. There was a supplement that was administered to individuals with a history of cancer, and in that supplement are questions about caregiving from the perspective of survivors. And we know from this report that about a quarter to a third of cancer caregivers reported making extended employment changes when their loved one had cancer. Another study called CANCORS, the Cancer Care Outcomes Research and Surveillance Consortium, was a study of lung and colorectal cancer patients. And in that study, there was an ancillary study of caregivers of those patients. And we've had a number of publications come out over the last few years, a few more recently, as you can see here, in the realm of caregiving. And so we know that caring for a spouse or a partner, as opposed to other kinds of caregiving relationships, and those with a higher number of tasks are reporting worse relationship quality, so the actual caregiving seems to be having an effect on the relationship. Higher levels of caregiver reported depressive symptoms, and fair or poor self-rated health among caregivers are actually associated with the patient reporting fair or poor perceived quality of care. So which suggests that it may be that patients are seeing the impact of their illness and their care experience is really affecting their caregivers as well. And then finally, the last study that's mentioned here, caregivers were asked about any kind of sort of nursing or medical skills that they needed to do as part of their caregiving experience and any training that they might have had. And not getting that training but needing to perform those tasks was associated with greater reports of caregiving burden. However, the training, for those who actually reported training, seemed to have increased confidence, which was then associated with less burden. So actually, training might be a way to increase caregiving confidence. So now I'm going to move on to interventions, because I think we're all interested and invested in improving the lives of patients and their families. And this is an area that is of, I think, deep importance and great potential. So as mentioned in the beginning, I've been involved with the development of some funding opportunities for researchers to try to develop interventions to support the success of informal cancer caregivers to help better support their own patients. And so we actually have a funding opportunity at the level of R01, which is about a 5-year grant, and the level of R21, a 2-year more exploratory or smaller grant, to help investigators develop interventions that help support caregiver well-being, patient health, and healthcare utilization. You can see the next due date there. And we've been able to fund 2 studies so far, with hopefully a couple more along the way. We're sort of right in the middle of that particular funding opportunity, which is that's still open and active. We also were able to sign on to a nursing institute funding opportunity, which provides an opportunity for investigators who are not just interested in interventions per se, but maybe interested in doing some mixed methods work or some observational work to look at palliative care needs of individuals and their families who have rare diseases, and that includes rare cancers. And these are some of the areas that we're interested in targeting with that funding opportunity. So things like psychological distress, the problem of prognostic uncertainty, social isolation, and decisional regret. And that is also active. And then I want to move on a little bit more specifically to talking about technology and then also integrating caregivers better and talk about some of the opportunities and resources we have been developing in that area. So we developed what's called a Small Business Innovation Research topic, or SBIR, to help to get small companies to develop platforms and digital applications to support informal cancer caregivers by connecting them to healthcare teams. So with the hopes that this technology would help alleviate cancer caregiving burden, assist caregivers in the managing of their care recipients' care, juggle their own needs, so participate in some self-management, some self-care, and then enhance those connections with the healthcare team. And we were able to fund 3 different companies to, over the next few years, develop platforms to help do just that. So Bright Outcome is developing an app that will provide really a caregiver support system to help address both caregiver and caregiving needs. Care Progress is developing a smartphone application to help caregivers access patient electronic health records and communicate better with clinicians. And then Medable is working on a digital application to assist informal caregivers with developing an interactive care plan for home-based care for cancer survivors. So we're looking forward to being able to connect companies with NCI so that they can use the best evidence in guiding their commercial solutions to this multifaceted problem. We've also, NCI has also worked with the American Cancer Society to create an interactive and engaging website called Springboard Beyond Cancer to connect cancer survivors with resources, including recommendations for how to stay healthy, information about managing symptoms and side effects from treatment, helping with coping, getting support, and then these are called action decks to help provide discrete, simple actions for survivors to help manage their health and well-being. But last fall, Springboard launched additional content and pages specifically targeting caregivers to help address many of their own specific needs. So you see here are the various pages, which are all clickable on the website. The URL is given at the bottom right, about what it means to be a caregiver, caring for your body, caring for your mind, finding meaning, what to do when treatment ends, and then also a section for caregivers who have a patient who is at their end of life, and even those who have passed on, and so support for bereaved caregivers as well. Now this next set of slides is more geared for healthcare professionals such as this audience. For those who may not be familiar, NCI, and specifically the implementation science team at NCI, hosts a platform called Research Tested Intervention Programs, the lovely acronym RTIPS, which now houses over 187 evidence-based interventions for program planners and public health practitioners, including material that can be directly downloaded and implemented at a practice or healthcare site. And all of the interventions listed have had results that were tested and published in peer-reviewed journals. Some of the content is free, some of it's proprietary, so there may be a fee, but there's a lot of content and curated content that's provided in sort of an organized fashion on the RTIP site. It's important for me to say that the programs posted are not necessarily endorsed or recommended by NCI, but the information is provided so that healthcare professionals can make an informed decision about whether or not an intervention program is right for their own site. So I'll just show you a couple things specifically about caregivers that you can find on RTIPS. As you go into RTIPS and I'll go back a second. As you start to search for programs, there's a bunch of filters that are put in place, so you can search by certain kinds of topics, everywhere from screening through survivorship and supportive care. The interventions that are targeting cancer caregivers are listed under survivorship and supportive care. That's why I have this box checked here. And then when you go there, and you kind of scroll down and you look for the targeted population of that'll say caregivers are targeted in these particular interventions, you'll find right now there's 6 that I found that actually do target caregivers or survivors and caregivers. And then you would be able to click on any of these to get more information about that individual intervention. So 6 is a nice number, but of course, it could be higher, and so we do encourage you and your colleagues to consider submitting programs, again, that have been tested and the results of which have been published, so that we can actually grow this area of the RTIPS website and we can sort of share successes across from site to site. Okay, so what are some future directions that NCI and other investigators need to be taking or trying to take in this space? So we definitely need, and I didn't get into this that much in this talk, but we definitely need more attention to measurement. There are actually few cancer-specific caregiving instruments. There are a few out there, but there's not enough out there that meet optimal standards of content, cause-effective criterion validity. That isn't to say every site needs to come up with their own measure, but we do need to be giving more resources and more thought to better measurement. We definitely need more observational population-based studies, ideally, particularly longitudinal, which is hard in caregiving when you're trying to study caregivers, because you typically access caregivers directly through patients. So there's recruitment and retention is even that much more challenging. I will say that the Detroit Rocks, which is a cohort study that was just recently started and is on African American survivors, is also collecting caregiver data, so that will hopefully be a great source of information on African American cancer survivors and their caregivers. We need more national surveys. I'm also happy to say that we have had some recent developments for some of the national surveys that are out there on health and the health of the nation that is actually looking specifically at caregivers. So the Health Information or National Trend Survey, which is run out of the division I work for at NCI and has been in place for over a decade, is now has a caregiving module out in the field. Last year, so we're talking HINTS 5, the cycle 1, now we're in HINTS 5 cycle 2 in the field, but last year's cycle had some what we call caregiving screening questions, that at least asked if people were serving as a caregiver and why, for what reason their care recipient needed care, and a few other questions related to caregiving. The behavioral risk factor surveillance system also has a caregiving module, and it's been in place since 2009, but in 2015, 24 states fielded the module, and then in, I believe last year, 2016, 21 states fielded it. So there's more sort of national data being collected on who's serving as a caregiver. We definitely need more of what I would call dyadic analysis, or analysis that looks at patients and caregivers together, certainly making the analysis more complicated, but ultimately leading to sort of more informed, giving us a more comprehensive picture of the health and well-being of both the patient and the caregiver. And we need more research in underserved groups. There's we don't know a whole lot about caregivers in general, but we certainly don't know enough about caregivers who belong to racial ethnic minorities, any that are socioeconomically disadvantaged, caregivers in sexual gender minority populations, caregivers for individuals with rare disease. So there's a lot of patient populations that also have accompanying caregiving populations that are not well studied. That all said, there's a lot going on in caregiving on sort of the national stage. So last summer, the National Institute of Nursing Research had a meeting called the Science of Caregiving, Bringing Voices Together, that gave a nice sort of state of the science on caregiving broadly. That is completely video archived, and if you're interested, you can go watch the two-day meeting online on the NIH Video Archives. It's a really great summit that I think inspired a lot of research and energy going forward. And in 2016, the National Academies of Medicine, formerly the Institute of Medicine, issued a report called The Study of Caregiving for Older Adults. I think it's called Families Caring for an Aging America. And in that report, there was a call for the development of a national family caregiver strategy. And one of the really exciting things about that is that just this last month, there was the Senate and the House both passed an act called the Raise Family Caregivers Act, which actually is going to create a national family caregiver strategy, and that bill was signed into law, I think just last week. In addition, there is another act that was put on the books a few years ago. It's a state-based act called the Caregiver Advise Record Enable Act, or CARE Act, which is targeting hospitalized patients and their caregivers. So what this act essentially does is three things. It calls for any patient being admitted to a hospital to be asked, or have whoever's with them be asked who the primary caregiver is of that patient, have that person's information recorded in the medical record, require or mandate that person be notified upon discharge, and then actually involve that person in discharge planning. So that act this is actually a bit out of date, this version of the slide. This act has been, I believe, passed in most states, although it's being implemented in different ways according to state. So the American Association of Retired Persons has been really the driving force behind that act, and anyone, if you are interested in learning more about what's going on in your own home state, you can go onto the AARP site, type in Caregiver CARE Act, and you'll find updates for your particular state. Okay, so this presentation was really about moving from where I think we need to go and where I think we are going, which is moving from patient-centric to family-centric care, because this is generally what patients, what most patients really care about. And another way of saying this is it's really moving from what's the matter with you to what matters to you. So yay, caregivers. It's an exciting time to be thinking about caregiving, given all of the recent developments in research and policy and in practice. And with that, I will take some questions. Thank you all for listening.
Thank you so much. This has covered so much, and it provided some hope. I'm excited to hear about the Raise Family Caregivers Act and so much that's going on in this area. So if you do have a question on the line, I see there's about 31 of us on the line. So if you do have a question, please enter it into the chat function so that I can ask Dr. Kent to address it, and we have some time here to go through some questions. I think to get started, I might just start with a question of my own. I'm wondering, you talked a little bit about how people who were in that younger age range of 25 to 54 had some more caregiver distress. The impact of cancer on their family was a little bit higher. I'm wondering if there's any kind of special populations of caregivers that we could be more focused on or offer more tailored resources for, specifically thinking of sometimes, there's elderly caregivers who are caring for a spouse who has cancer. Maybe they have a cancer or another chronic illness themselves. Or they're just dealing with their own kind of just aging issues. I'm wondering if there's any interventions or programs that would be especially targeted for those kind of special populations.
Yeah, thank you for that question, Jackie. I think the short answer is yes. The longer answer is I think it does require some work to find and adapt to a certain extent an intervention to fit the unique needs of a particular population. You mentioned some specific populations like, young adults who are serving as caregivers, and also older elderly individuals who are serving as caregivers. I think one of the nice things about sites, and our tips is not the only one, but about sites that actually post information about programs or interventions that are tested, is that you can get a sense of pretty quickly of whether a given program might work for a given population. There are other organizations too that also list interventions. The Rosalind Carter Institute for Caregiving is another one, and I'm sorry I didn't include that in my slides, but they also list a number of interventions by sort of disease domain, and cancer is one of the domains that they look at. And then there is also, too, a recent review that was put out by Betty Farrell to sort of update a systematic review that was conducted earlier by Laurel Northhouse that actually reviewed a number of caregiving interventions that targeted caregivers for, in terms of helping to provide supportive care, manage symptoms of their care recipients. So, and what the notable thing I'll say about that review is that review was published in this last year in 2017. Well, the prior review was in 2010, and since from 2010 to 2017, when that systematic review was put in place, the number of interventions has just exploded. So I think that there are a lot out there. I think finding the right one can be a bit of a challenge and somewhat of a trial and error. And so I would say coming at it from both ends is probably a good approach. So thinking about, reaching out directly to patients and caregivers who are willing to share, either doing something formal like a focus group or a set of individual interviews to really get at what are the real needs, I think is really important. I think it's important to ask not just patients themselves, but also the caregivers. And sometimes you have to do that separately to really get the full comprehensive picture. But that seems to be one of the best ways that various sites have been sort of locally helping to create programs or find programs that would help address needs. So I think that might be a good way. And then reaching out to various caregiving experts. Hey, these are the needs of my particular patient and caregiver population, can you help me find a particular program that might work? Those are some of the approaches I think I would take.
Sure, that sounds great. Thank you. Yeah, I had forgotten about Rosalind Carter, that program too. That's a great resource. Another question here, I'm wondering, and again, if you have questions on the line, you can enter them into the chat function, and they're coming to me, and I will ask them for you. Another question, so just thinking about earlier in the presentation, one of the slides, you talked about future directions for research and the need for more attention on measurement. So for people running, maybe not doing research, but running programs for caregivers, is there anything in particular that we need to keep in mind for measurement for our programs, especially if we're going to publish anything about our programs, that we need to make sure that we're measuring as we're, before and throughout and at the end of the program for a caregiver?
That's a great question, and something I didn't mention. Your questions make me think of when I mentioned the funding opportunity announcement that we had for developing interventions. One of the stipulations of that announcement is that investigators target not just patient outcomes and caregiver outcomes, but also that they have some measures of the impact on the healthcare system. Most people are interpreting that as utilization. And that can be broadly defined, but to try to see, does implementing a caregiver program in a given healthcare delivery system, does it actually make a difference overall to that healthcare delivery system? And maybe the answer is it's neutral. Maybe the answer is it's actually effective, but it's costly. Maybe the answer is that it actually helps reduce over the right time scale adverse health, or I should say suboptimal healthcare utilization. But it's important to be thinking, big picture. If you're providing support, let's say you set up, because I know some hospital systems have set up, say, hotlines for caregivers. So after discharge, and this isn't necessarily specific to cancer, but here's a hotline you can call if you're a caregiver. We're here to help you all hours of the day address whatever needs that might arise in the middle of the night, so that you don't have to pack up your sick loved one and take them back to the emergency room. And some systems have seen booming use of those hotlines, and that's a cost for the system. But does it ultimately then lead to less people taking their loved one to the emergency room, less hospital readmissions, shorter hospital stays? I mean, so thinking what would an administrator of your given system, clinic, site want to see in order to invest more resources into helping families? I would think about that question as you're treading into the waters of wanting to implement a new intervention.
Okay, great. So I got a question in here about assessment and interventions related to a social net and social services. Many caregivers in rural areas don't even have their own computers and can't pay the cost to drive to treatment, things like that. So concern about the Caregivers Act is putting so much emphasis on hospitals doing a better job with discharge planning, which is great, but then apps also, access to those apps. So how do you help people who are really in maybe rural or frontier sort of areas and don't have kind of the social network or the means to access programs that are at treatment centers or hospitals?
I think that's a really good question, and it's a hard question because I think the landscape is there's sort of accelerated changes happening in some places, and then no changes at all, or some places maybe feeling left behind by some of the race to develop technological solutions. There's no easy answer other than to say, I think in many cases it's appropriate for, even if it depending on the sort of the catchment area and the scope of a system, if there's a drive to develop technological solutions, that there should always be options to be lower tech, and that frankly tech is never going to replace touch. So although tech can help make us more efficient in some areas, it should always be an assistant to, high-touch care delivery. So it's never going to replace, picking up the phone and calling a family member who can't come in or doesn't have a computer or doesn't want to use a computer. And that's sort of then the variation can mean asking a lot of various healthcare providers and various healthcare professionals. But the reality is I think using those in-person encounters to really ask the pointed questions of what's needed here, asking questions not just about how the patient's doing, but how the caregiver, how the family is also doing, is an opportunity to help customize or help tailor needs to that given situation or that given population.
Okay, great. So we have a little bit of time yet still, so if you have any questions, feel free to put them in the chat function. The next question here that I'll ask is kind of stemming from the tech question, but in the opposite direction of using tech. If there's any kind of tools, perhaps tech tools, apps or resources that you think are especially helpful for caregivers, specifically wondering if there's anything that are maybe for elderly caregivers to keep track of all the duties of caregiving, but just broadly still, what are some of if there's any tools that you think are really well done or would recommend?
Yeah, so part of the reason why we came up with the SBIR concept was that we didn't feel like there was enough out there to do just that. That said, there are, a number of different apps out there to help manage tasks in one place. I can't necessarily point out to one specifically, other than to say I think that they are coming. I don't think there is, even if we develop, state-of-the-art, state-of-the-science, cancer caregiving apps, it's likely never going to be able to do everything that an individual person or an individual family is going to want it to do. But that said, there are a number of sort of off-the-shelf or commercial apps that can manage tasks in one place. Some people like, sort of time management software solutions to just put everything there and not necessarily that aren't necessarily health-focused, but just, that connect, via smartphone applications to provide sort of in someone's hand or someone's palm reminders. So, Google and other kinds of programs can sort of do that in a custom way. But frankly, some people like, the old paper and pencil system. I think that peer support groups often have good suggestions of, systems that work best for a particular sort of demographic or a particular patient population, and that's actually often a very good source to go to first. So I think I would recommend, starting with peer support programs, either locally or online, based on whatever, the patient population of interest is.
Great. One other question here coming through, just if there's any advice you have for anybody considering the R01 funding or the R21 grants, looking into applications for that, any advice you have for somebody pursuing that?
So first of all, let me just encourage going for it. Particularly, if you are a junior or an early or investigator, or you're new to developing interventions, don't shy away from something like this. We need quality interventions, and we are very interested in helping early stage and new investigators get funding to do this important work. My first question is going to be to read through the first piece of advice is going to be to read through the entire funding opportunity announcement in detail. And as your ideas get better developed, to reach out to the program officer that's listed. And this is true for any funding opportunity announcement at NIH. There's always going to be a person at the bottom, a contact. You always want to email that person, set up a time to talk. Ideally, have some of your ideas in the form of aims is a really good way to go. Let's set up a time to talk to get some pointed feedback on the idea. And in caregiving, caregiving is one of many different spaces that is pretty interdisciplinary. So you have, palliative care, nursing, health services researchers, epidemiologists, behavioral interventionists, who are both trying to move the needle on developing interventions and also reviewing the science. So as you're developing an idea for something like this, you're going to have to be thinking more applied and less disciplinary specific. And be persistent. Pay lines are not necessarily lower than they've been in the recent years, but it's hard. It's hard to get NIH funding, and the people who tend to get it tend to keep trying and trying and trying. So don't, know that you're in good company if your grant gets scored or doesn't get scored, but you don't get funded. That's more common than not. So go for it, reach out to your program officer, and be persistent. Those would be my 3 kind of pieces of advice.
Great, thank you. So it's about 4 minutes until the top of the hour. I think I'll just ask one final question. It looks like there's none others that are coming through, so just one final question for me. It would just be kind of where you see the future of kind of caregiver research, caregiver education, caregiver interventions going. What do you kind of see as the future, and what do you hope will come of the future?
Yeah, that's a really good overall question. I mean, I think that we're going to continue to see more technology-mediated solutions, but they will never, as I alluded to earlier, they will never replace touch. They will never replace in-person or on the phone encounters with the healthcare system. I think we're seeing people living longer and longer with cancer, which is a wonderful thing, and it's a success to be celebrated. But we're also, potentially going to be faced with individuals who have late emerging and also long-term sequelae or consequences from their treatment. So, we're relying more and more on family and on caregivers, and I don't think that that's going to change. But I do hope even just having these conversations will help people realize the enormous amount of support that we are relying on caregivers to provide, and also sort of elevate the identity of what it means to be a caregiver. That in addition to, we often focus, and I know I focused my talk on sort of the burden that we're putting on caregivers, but caregiving itself is a beautiful, sacred calling that most of us will either have a caregiver or be a caregiver in our lives. And so to sort of recognize and champion that role is what I hope the future holds, and I'm seeing evidence of that already occurring. So.
Great. Thank you so much.
Parting thoughts. Yes.
Yeah, thank you.
It's been a real pleasure.
There's no other questions that are coming through, so I just want to thank you, Dr. Kent, for your time today and for sharing all of this, kind of just your wisdom about the caregiver interventions and programs with us. I learned a lot, so took a lot of notes. So I really appreciate it. And to everyone on the line, CPEN would like to thank you for your time to participate in this webinar. If you have any questions regarding this event, please send them to info@cancerpatienteducation.org, and we'll be happy to follow up. Also, once you leave the WebEx webinar, you'll get a survey, and so please take a moment to fill out the survey and let us know what you thought about the webinar and what sort of topics you'd like to see in the future. This webinar, like I said earlier, is being recorded, so it'll be available to CPEN members in the near future. So thank you all, and have a wonderful rest of your day.